Hello. Yes. Hi, good morning or afternoon or whatever it is right now. I guess it's noon. Good afternoon. Um, I'm really happy to be getting this lecture series started. As you know, we've been talking a bit about initiatives that we're building in the school, and climate change and health being one of the key initiatives that we're working on. As you know, we started the climate change and health initiative was kicked off on April 2nd with a symposium we held on the topic. This is the kickoff of another initiative that's part of that program, which is the Dean's Lecture Series on climate change and health. And we're pleased to have the first speaker in that lecture series. I'm going to turn this over to Melissa Gonzalez, Chair of the Department of Environmental Health Sciences, who is heading up our climate change initiative, who will, who will introduce our speaker and get the program started. Thank you all.
Thank you, Dean Leviste. Dr. Kioumourtzoglou, we were practicing this. She has got a very interesting name, Dr. Kioumourtzoglou. There we go. I can speak Greek. Is an environmental scientist, engineer, and epidemiologist. Her journey began at the Democritus University of Thrace in Xanthi, Greece, where she obtained her degree in environmental engineering. Then she went on to get her Master's of Science in Public Health from the University of North Carolina at Chapel Hill and her doctorate from the Harvard Chan School of Public Health. She's currently an associate professor in environmental health sciences at Columbia University's Milan School of Public Health, where she researches air pollution, epidemiology, climate, and health impacts. I want to point out a little bit about her research. Right now, she's got quite a few active grants. Her own grants focus on air pollution, pregnancy loss, and cardiovascular disease in American Indians. And she's going to be talking about a lot of her different research that covers these areas in collaboration with public health, climate change and health. But she has a wide range of collaborations that I wanted to point out because her health outcomes that she's looking at associated with air pollution exposures range from Alzheimer's to lung function and mitochondrial DNA in children to investigating spatiotemporal patterns at the nexus of air pollution, climate change, and health. So please join me in welcoming Dr. Kioumourtzoglou, Dr. Marianthi. She says even in undergraduate days, they called her Marianthi. So Dr. Marianthi, thank you so much for joining us today. Please help me welcome her. Thank you.
Thank you so much. Let me change. I found. Thank you so much for the invitation to come here and for the hospitality. The invitation is one thing. You don't realize, like, it felt so nice. I felt so welcome from the minute I received that first email. So thank you very much. And I'm sorry for my last name. It's really an impossible name. No one can say it. So we all get a test after this. Whoever gets to say my last name can get out of the door. I'm joking. No, no test, I promise. I am very honored to speak here in Tulane at the inaugural Dean's Lectureship on climate and health. And I'll focus my research on climate and health looks at all climate sensitive exposures. Air pollution is one, of course, but also temperatures, heat waves, temperature variability, wildfires, floods. Today, we'll be talking more about my work on tropical cyclones. So this is a brief outline of what I'll be talking about. It's a bit long because I read the agenda wrong. I thought we had an hour and a half. So if you get bored, let me know and I can speed up. Or if you need to leave, of course, feel free to stand up and leave at any point. But we'll start with how we define tropical cyclone epidemiology. So tropical cyclones are devastating to societies and human health. The National Weather Service defines a tropical cyclone as a warm core, low pressure system without any front attached that develops over tropical or subtropical waters and has an organized circulations. There's not very consistent evidence about changes in frequency of tropical cyclone because of climate change. This is debated. Some scientists say there are, some scientists say there's not. But the one thing that everybody agrees on is that tropical cyclones are becoming increasingly intense. So they're destructive and they're disruptive, with devastating impacts on human health through direct or indirect pathways. But most studies to date have focused on single hurricanes. Katrina, Sandy, Harvey, which is, we are really lacking a systematic analysis of the health impacts of tropical cyclones. And the reason for that is because we were lacking exposure data, comprehensive exposure data that are harmonized to allow us to do these types of studies. Enter Brooke Anderson, who's a collaborator of mine, amazing environmental health scientist, associate professor at Colorado State University, who curated an open source data set with county level exposure to tropical cyclones for use in health studies specifically. So that data set includes, well, all counties, that ends up being called US counties, or eastern rather US counties, sorry, for all landfalling or near land Atlantic basin storms starting in 1988. Right now, the data set only goes to 2018, but they're actively working on updating the data set. It has validated measurements, again, other data sources, and it's enabling us, climate and health research scientists, to comprehensively assess the impacts of these tropical cyclones on human health. Just a minute. Sorry about that. So I'll just give an example of 3 studies we have conducted using these data. Starting with quantifying the impact of tropical cyclone exposure on hospitalizations within a week following exposure to tropical cyclones. So the study aim for this study was to evaluate if tropical cyclones are associated with cause-specific hospitalization in the United States the week following exposure. And this is a paper that my then postdoc and current assistant professor in my department, Robbie Parks, who's an amazing scientist, led. So for this, we used Medicare hospitalization data. Medicare is a nationwide insurance that covers everybody in the US that's above 65 years old. It's an amazing resource. We have daily hospitalization data at the county level from 1999, and this study only went to 2014. And we restricted analysis to counties that experienced at least one cyclone during the study period. And for outcome assessment, we used more than 15,000 diagnostic codes, and we grouped them in 3 causes, big causes, that basically covered about 95% anyway of all hospitalizations. We did exclude causes that rarely occur in older adults. So they were, for example, we had some diagnosis for pregnancy complications, which may have been a mistake at this age group. These are the hospitalization data. And as you can see, as expected, the largest number of hospitalization was due to cardiovascular disease. That's the green there. But they have been going down until 2014. Things may have changed after that. So for exposure data, this is what Brooke put together and we were able to use. We use these R packages that make exposure assessment very accessible to us. And these provide daily estimates of maximal wind sustained speed by county. So our main exposure was tropical cyclones altogether. These are winds that are above 34 knots. And then we also looked at gale to violent force storms that are, storms with winds between 34 and 64 knots, and hurricanes that are specifically defined to be above 64 knots. And ultimately, we had about 900 counties in 29 states and DC with at least one tropical cyclone. And in our data set, all cyclones were between May and November, occurred between May and November. So this is, and interestingly, right now, if we had conducted this study until now, we would have included Los Angeles, but not until 2014. So yes, this is basically the map. It goes, 20 was the maximal number of hurricanes experienced in, I don't remember the name of the county, in North Carolina, Florida, and Louisiana being the 3 states with most exposed to tropical cyclones over our study period. So we used conditional quasi-Poisson analysis. Basically, we matched counties on day of week and month, which is amazing because that way we eliminate any potential confounding by factors that vary across counties. We non-linearly adjust it for long-term trends, and we use as an offset the county and year population. We use unconstrained distributed lag terms for lag 0 to 7 that basically allows us to smoothly model the response to the exposure the week following exposure. We adjusted for temperature, and because we looked at 13 outcomes, we also Bonferroni corrected the confidence intervals. And these are our main results. This is a bit of a busy slide, so I'll walk you through it. On the x-axis, first of all, each panel is one of these 13 categories. So up here is cardiovascular diseases, respiratory diseases. On the x-axis is the percent change in the rate of hospitalization for each outcome, with 0 being null, positive being harmful, negative being protective. And each point, starting at the top at 0, is a different day. So lag 0 is the day of the hurricane, down to a week afterwards, day 7. So as you can see, a few things pop up here, right? First of all, respiratory diseases are up and stay up the entire week following a hurricane. Same as injuries, maybe not the day off, that's null, but definitely following the week. What we do see is that for most outcomes, the first 2 days are protective. And you'd ask, Marianthi, you just said hurricanes, we haven't studied them a lot and their impact on health, but how can they be protective? Remember that this is hospitalization data. So unless someone has an emergency, if they have a routine checkup or a scheduled surgery or an appointment, they are not going to show up at the hospital during a hurricane. So that's why for most outcomes, we do see a protective effect day 1 and day 2. Now, in the case of cancers, because obviously these have huge latency periods, et cetera, we don't see an increase afterwards at all. These appointments were rescheduled later. For outcomes like cardiovascular disease, we do see an uptake after day 1 or 2. So people who missed these appointments the first 2 days did show up at the hospital later. I think the cumulative weekly for cardiovascular diseases ends up being actually null because they cancel out the 2 effects. And we also looked, importantly, as I said earlier, at hurricane versus gale to violent storm. And the reason we really wanted to do this, and this will keep showing up in the future slides as well, is because everybody focuses on hurricanes. They make the big news, they're huge events, right? They're extremely disruptive and destructive, and we should focus on them. But tropical cyclones that are less extreme are way more common and more frequent. And people, they don't make as much the news. So we wanted to see if there are associations with these weaker wind cyclones. And indeed, we do see, of course, as expected, in purple is hurricanes. Huge effect estimates. Like if you see hospitalizations day 2, that's more than 100% increase in the rate of hospitalizations. These are very big numbers. Nonetheless, it's about 25% for the tropical cyclones of weaker winds. That's also very large and important. And we saw in general the patterns were the same, but with the temporal patterns of association, but with larger magnitude associations for hurricanes. So that was, we published that study, and that's a week following exposure. But then no one has looked, again, comprehensively. They have looked at single hurricanes, but comprehensively at the impact of these big destructive events, the months following exposures, not only the weeks. So we wanted to see mortality now associations following a hurricane up to 7 months of exposure, up to 7 months after exposure. So this is a second paper by Robbie Parks again to evaluate if tropical cyclones are associated with cause-specific mortality in the United States in the months following exposure. We are not using Medicare anymore. Now we're looking at National Center for Health Statistics to get mortality, cause-specific mortality data. That includes all ages. These data are monthly at the county level. Now we have data to go back to 1988. So this is a much longer study period. Again, we're restricted to counties that experienced at least one cyclone during the study period. And similarly to the previous study, we used ICD 9 and 10 codes to group these to 6 categories of death causes. These are outcome by the 6, you can see the 6 groups that we looked at: cancers, cardiovascular diseases, infectious diseases and parasitic disease injuries, neuropsychiatric conditions, and respiratory diseases for male and female, cardiovascular as before being the largest group. With brown here is the people, Medicare eligible people above 65, with this light blue is people below 65 years old. And on the x-axis are the months. So you see that there is some seasonality in most of these outcomes, but not all. So this is very similar to what we saw earlier. This is all cyclones. Now these are many more years, so the max goes to 30 instead of just 20, but it's exact same pattern as before. And this is the subset of this that's only hurricanes. Same pattern, just smaller numbers, because these are much more rare events. So for our statistical analysis, it's similar to the one I described before. In this case, though, we're doing this in a Bayesian framework, but we use Bayesian conditional quasi-Poisson models, matched counties and month, adjusted nonlinearity, used for nonlinearity in long-term trends, use an offset, looked at smoothly how the effects vary up to 6 months post-exposure, and we also adjusted for same month temperature. And these are our results, and I'm very sorry that it's slightly small, and also the setup is different than before. So now on the x-axis is the lag, and these are months after exposure. So 0 is the lag, this is the month that the hurricane or the tropical cyclone hit. Percent change in hospitalization rates is on the x-axis, on the y-axis, sorry. Each panel is a different outcome, and with this orange here are the hurricanes, the more extreme events. And with this, it's supposed to be blue. I don't know what colors it looks like now, maybe dark gray, is the weaker winds. And it's interesting enough that for certain outcomes, we do see effects for many months following exposure. So for example, cardiovascular disease, we see increased effects the same month and the following month. For infectious and parasitic diseases, we see effects up to 2 months after exposure. Similarly, for neuropsychiatric conditions, and this is mortality, not hospitalization rates, right? So neuropsychiatric conditions, and this include the mental health outcomes that we're talking about during breakfast, these go up until almost 3 months after exposure. Injuries, of course, being the very big one, the month of either cyclone or hurricane, and then respiratory diseases up to 2 months afterwards. So we do see that even the 2 months, we keep seeing adverse health outcomes, mortality in this case. So this is excess mortality. I will present. This was Robbie's idea, I will say, this paper that we did, because he felt that, okay, we are showing these associations, but how do we actually count mortality attributed to these tropical cyclones? And it seems like every county, every state, every cyclone does it in a slightly different way. So he wanted to quantify this in a systematic way. So what we did, first of all, what is excess deaths is basically the difference between the expected number of deaths had hurricane or cyclone not come through and the observed number. And this is essential for understanding public health burden of the cyclones comprehensively across the country. It's relevant to policies on preparedness and mitigation, but the problem, as I said so far, has been that the methodology for this is quite inconsistent. So results are not comparable across counties, hurricanes, cyclones. So our goal was to comprehensively quantify the cyclone-attributed excess deaths in the United States within the 2 months following exposure, both for gale to violent force storms and hurricanes. So the way we did it is we developed a Bayesian ensemble of 16 predictive models using predictors like long-term trends, seasonality, temperature, etc., population data. And we predicted deaths had a cyclone not occurred. And then we estimated the difference. Basically what this means, this is Orleans County, Louisiana here. So the date is on the x-axis, death rate is on the y-axis. Every black dot is observed data. These are the actual death rates. So we fit a predicted model to predict what the death rate would have been based on the county-specific patterns. And here, these are the counterfactual ones with uncertainty, what we predicted for the 2 months, right? These are the counterfactual death rates if no hurricane had occurred. It would have been here. This, and if you see, this is 2005, so this is Katrina. And this is the observed deaths in the 2 months following Katrina. So basically what we did is take the difference of these two. But we did this, before I show you the results, we did these for all cyclones, all counties across the United States from 88 onward. And what we found was the deadliest hurricane was indeed Katrina in 2005, with about 1,500 total deaths. The largest number was in Orleans Parish right here, with about 700 deaths. And these are the credible intervals that we estimated. The largest count in a single state was Florida in 2017. That was Hurricane Irma, again, 1,400 deaths. And in the counties where the posterior probability that excess death was above 0 was more than 95%, that means basically in counties that we did have deaths attributed to hurricanes, in this case, we found that 3,000 people died because of hurricanes. Here's the most interesting part. When we look at gale to violent storms, it's almost 16,000 people. Hurricanes are the ones, Katrina and Irma are hurricanes, and these are very destructive and are killers, really. But if you look at the total burden of the smaller ones, is 5 times larger. And we won't go through this, but these are the results for the deadliest by county counts. So it's the estimated excess deaths by count, and here, and Katrina in Orleans Parish, as I said, was the deadliest one by far, with more than double than the next one, that was Rita in Texas, in Harris County. So this is very interesting. This shows the exact same results. On the x-axis are all the hurricanes in the year, or not hurricanes, and cyclones, but these are hurricanes because these are named. And on the y-axis are all the states. And as you can see, this here is Katrina, this here is Irma. But what you can see is the numbers. This is the number of excess deaths. The darker it gets, it's more positive. The bluish, grayish, that's negative. As you see, we have a few negatives. That means that we didn't see as much mortality. In fact, it was decreased compared to the expected. This could be because of evacuations, of other reasons. But we do see higher and higher and higher numbers in more recent years. And we think this is because of the intensification, did I say that? Okay, thanks, the hard word for me, of the hurricanes with climate change. So what does this all mean? Tropical cyclones are adversely associated with cause-specific hospitalizations and mortality. Fun story here. When we did the mortality paper, it was published in JAMA, and JAMA is, it was my first JAMA paper, and it's a very big deal, and I was super proud. So I called my mom and I said, Mom, I got a paper at JAMA. It's amazing. And my mom's like, oh, congratulations. She's not in the field. She has no idea what JAMA means, but she was happy with what I said. And she was like, oh, congratulations. What was it about? And I said, it was hurricanes and mortality. And my mom, there's a pause on the phone. She was like, you get money to study that hurricanes kill people? Really? And which was very funny. And indeed, if you say to someone that that's what I do, so it's like, yeah, I could have told you that. But I guess that talks, and again, it's back to the discussion we had during breakfast about the communication, that all the nuances and the importance, we didn't do this to see if hurricanes kill people. We knew that, right? But this got lost. So that says a lot about how we communicate our findings, as researchers, and the importance of it. But here, for example, what did come out that we did not know was that we did observe very robust associations with gale to violent force storms, not only with hurricanes, in fact, 5 times larger numbers, which is amazing. And look, it's astounding number. And because these events are much more frequent and the exposure prevalence is much higher. And so, yes, we did say, as I said, larger numbers due to these smaller storms. And we have hypothesized both direct and indirect pathways. And I'm happy to discuss this at the discussion part of this if we make it there. Hopefully we will. So in summary, we do need more research to characterize the pathways of pathophysiology. We do hypothesize the injuries are clear, then maybe due to power outages, people who depend on medical equipment, this is cardiovascular diseases, or respiratory outcomes may be impacted. There might be mold, but we don't there's a lot of stress involved, obviously, especially if you have to be evacuated, right? Or if you lose your house, your home. But we don't really know the exact pathophysiology. So we need more studies on, on that aspect of things. Our studies obviously had limitations. All studies have limitations. We used administrative data. So we assumed the address that was on the administrative records, which may not have been the address of people. We only looked up to 6 months post-exposure. So that's too short for certain outcomes. Our analysis was at county level, so that means there's measurement error there. We assessed the dichotomized exposure, hurricane yes, no, cyclone yes, no, but this is an oversimplified approach. Obviously, this is an extremely complex exposure. Was there flooding? Was it a fast-moving storm, slow-moving storm? Were there damages in the infrastructure? And we only assess short-term exposure, and that means 1 hurricane at a time. Which brings us to challenge number 1. So now I'll stop talking about cyclones specifically, and I'll open that to more general discussion on how we assess exposure to these very big, very destructive, increasingly frequent and intense, more frequent and intense climate exposures. There are many studies, all the studies if you've seen on heat waves, on tropical cyclones, as I showed you, on wildfires, they all look at short-term effects, short-term exposures, 1 wildfire event, 1 week of wildfire smoke, 1 heat wave at a time. But what happens for long-term exposures? How do I assess that? So going back to the cyclones, how does a long-term exposure to cyclones look like? Is it the total number of cyclones someone has experienced in their lifetime or in the last 5 years? Is it the average number of cyclones per year? How do we incorporate information on intensity and cyclone fixtures? Are any 2 cyclones interchangeable in exposure? Or even about frequency, right? Is 2 cyclones in the same month the same as 1 in June and 1 in October? most of these exposures, not only cyclones, but as I said, wildfires, heat waves, floods, they are very sharp, very discontinuous, and extremely complex. Each exposure is a mixture in it by itself, right? So the differences in how we define things could lead to different results. So we really need well-defined and stated research questions. It's really essential to understand the results that we see and be able to compare across studies, same thing, apples to apples. So the example I'll give here is on wildfires, which are obviously getting much more frequent due to climate change, much more intense. And this is a study that I conducted with Joan Casey, who is a colleague. She's now at UW. She does phenomenal work on emerging exposures. And we wanted to start conceptualizing how we can assess exposure, long-term exposure to these things. And we just use wildfire PM2.5. PM2.5 are fine particles. These are the tiny little particles that can make it deep into the lung, and from there induce systemic oxidative stress, systemic inflammation. PM2.5 has been associated with many adverse health outcomes. So this is just an example, a case study on how we can start defining long-term exposures. So we came up, we went back to our epi-basics. How do we define exposure for a health study? And we came up with some example definitions that all can be characterized by frequency, duration, and intensity, right? And these are, again, 5 examples. But what's important here is this is very small and you don't have to look at it very closely, but the bottom line is its little square is the 5 metrics in a different year. So the only thing that I want you to take out of this, these are correlation matrices, is that these do not look exactly the same from year to year. These do look different. And in fact, our case study focused on California. This is spatial patterns of these 5 different metrics and temporal patterns by year. And again, the details here are not that relevant. The very important thing, though, is that the different metrics have very spatial and temporal patterns. So depending on which one of these we select, we may find different results. That does not mean that the results of one are wrong and the results of the other are correct. They are assessing different things. So when we are starting a study, we need to clearly think, what do we want to assess? What is important here? Which definition better fits our research question? So that was challenge number 1. Challenge number 2 is how to conceptualize a climate threat mixture. So most studies have focused at one climate-related exposure at a time. Heat waves, I just presented 3 studies only on cyclones or on wildfires, but many of these co-occur with variation across space and time. So for example, heat waves and droughts, tend to co-occur with feedback loops between processes that intensify both drying and heating. Hurricanes and flooding is another pretty common one. Or what happens if you have a hurricane followed by a heat wave, right? So this is now we're going back to a mixtures problem. And there is a lot of work in the last maybe 10 years on how we can assess exposure to mixtures in health studies. And again, the most important thing always in any study goes back to the definition, the research question. What do we want to study? So for mixtures analysis, even to pick a method for the analysis, the statistical method, sorry, I just smiled at the, I'm very sorry. Depends on the primary research question. So I also do a lot of work on mixtures, and we've come up with this like schematic of what are the main mixtures question that someone may be interested in. So like it's overall affection of the whole thing, or what is the most important or toxic or harmful exposure? Do these things interact with each other? Do they mediate one the effect of the other, etc.? So when we're talking about climate exposure, is it really as simple? And if you've never done mixtures analysis, let me tell you, it is not simple. So is it as simple, not simple at all, but at least as just mixtures analysis of chemicals? And no, it just even gets more complicated, right? Because now every single exposure, first of all, is a mini mixture by itself. Tropical cyclones, we just discussed this, and that's akin to total PM 2.5, right? PM 2.5 is basically a marker of the air pollution mixture at each space and time point, but has important differences for analysis. It's not the same as PM 2.5. The second one is positivity. If I want to do a nationwide study, as I do, right? Oh, positivity, sorry. Positivity assumption means that given covariates, everybody in my analysis has the probability, has a non-zero probability of being exposed. So if I were to look at heat waves and hurricanes in Washington state, they do not get hurricanes. So I cannot include that in a nationwide analysis. I would violate my positivity assumption. Snowstorms in the summer, I cannot throw a nor'easter with heat waves in the same analysis. So we have very different mixtures by region and season. So how do we work around that? We could stratify things, sure, but the results are potentially non-comparable across strata. How do you compare, analysis that does wildfires and heat waves in one state versus floods and hurricanes in another state? Are these comparable? And also, if I keep splitting, these all are, yes, they are increasingly frequent, but they're still quite rare events. So if I keep cutting the pie and cutting the pie, then I will run into power issues, statistical issues. Are there any solutions? We are starting to think about that. We, of course, can always develop new methods or extend new methods. This can be in collaboration with biostatisticians, always they are our best friends. We can assess exposure to patterns of co-occurrence, taking into account the spatiotemporal dependencies in the data. Also, this data, one, we have to get access to the data, as I said in the very beginning, and these are huge, huge, huge data sets. So we also need the computational ability to be able to analyze this data. We can create indices of co-exposure, and then if the results are similar across suitable comparison groups, could that indicate an overall effect? Maybe, maybe not. We'd have to think about that. And then we also have to think about whether we want supervised versus unsupervised patterns of co-occurrence. Supervised patterns of co-occurrence, that means that the patterns we identify depend on the outcome, could be very interesting to identify pathways. Unsupervised, independent of outcome, are better for informing policy action. So these are all questions that we need to think before even starting to develop these methods. So in conclusion, climate-related exposures are and will increasingly play a key role, are already playing and will increasingly play a key role in our lives and in our health. Exposure assessment has been an issue. We don't have harmonized and easily accessible data sets. The reason why we don't have more studies on floods, for example, is that flood data are not great yet. And even with hurricane data, amazing data set, but it's binary. Cyclone, yes. Exposure to cyclone, yes, no. It doesn't say much about the wind or the rain or other characteristics that come with the cyclone. But we can leverage image and video and natural language processing for improvement of these new data sets and validation. But the most important thing, as always with any of our analysis, is that we need well-defined metrics of both short and long-term exposure that will help us interpret the results, that will help us understand what we're doing and compare across studies, and also well-defined questions to assess exposure to multiple co-occurring climate-related exposures in health analysis, which is also key. So bottom line, well-defined research questions and metrics all around. So with that, I would like to acknowledge my amazing, amazing group because they are doing all the work. So I get to be here and present. Robbie Parks is here, and his is most of the work that I presented today. This is Brooke Anderson, who developed the hurricane exposure R package and made this all possible at Colorado State. And this is John Casey at UW that we're working on wildfires together. And with that, yeah, that's my last slide. Now, happy to take any questions.
Thank you for the nice presentation. I really loved it. And I told you that I've been following your and Robbie's work from the beginning. So as you already mentioned that it is really very challenging to define, especially the tropical cyclones. So for the county level, as you assign the exposure at the county level, so how did you define that? Like whether the cyclone has to hit the full county or partially of the county?
It was simpler right now, and it was the maximal sustainable wind and the county centroid. Which, yes, which would induce exposure measurement error, correct.
Okay.
Yes. To be fair, hurricanes, especially hurricanes, cyclones, smaller cyclones as well, are pretty large in scale. In the east, we have smaller counties. In the west, it would be more of an issue. So there is exposure measurement error, maybe not as influential in this case, but of course, there definitely is, yes. In discussion with Brooke, she does want to develop this at smaller like zip codes, but she's prioritizing things to do and extending to more recent years, especially the more recent cyclone hurricane seasons is the first priority, and then to a smaller scale.
Was you able to capture, like, especially during tropical cyclone, people moved from one place to another place? Like, did you assign to the exposure where the people?
Administrative data, that's a limitation of administrative data. We do not have this information. So that's the difference between having a localized study where you could have all this information versus, a study of 20, 30 years using, millions of records. Yeah.
I do realize that.
Yes.
Thank you.
Thank you.
Well, thank you for the informative presentation.
Thank you.
Having experienced Katrina, my question is, what segment of population, let's stick to one example, mortality. Your numbers for 1490, I think it was close to 1800. So you are short about maybe 300 people died. What segment of the population did you study? We have people who stayed, who could not leave because transportation, very poor. People who evacuated and came back. People who evacuated did not come back. The city was 460,000. Now it is a 360,000. We lost about 100 and 120,000 people to Houston as well as to Atlanta. Also, I would like to see something done about the extent of damage and the diseases, all those variables, especially cardiovascular diseases. When somebody lost his house, is different than somebody came back without having his house destroyed.
Absolutely. And these are extremely, extremely important questions. We, three different questions. The first one is about how we counted, and we just used existing records. We didn't really follow people. So we used the county-specific recorded number of deaths. So we predicted had exposure not occurred, and the observed, and we just took the difference. Obviously, this does not account if someone evacuated and died elsewhere, right? They would. So our method definitely has limitations. We fully acknowledge and recognize that. And I think very powerful thing to do because we did it comprehensively across the United States, but these types of work and analysis do need to be coupled with local knowledge and data to compare and understand better specific events. So that was number one. Number two, about infrastructure damage. We are already thinking about this, and it is extremely important. The way we want to do it, and we're discussing about doing it, is, as I said, leveraging video data, satellite data to evaluate damage that way. We're working with computer vision experts and computer scientists. The tricky part there is we're not on the ground. And again, that would be the studies that I'm conducting, as you say, are nationwide. They do need to be coupled with local studies, because I can use satellite data and give a value or say, yes, this was damage. This was it the experience, the lived experience? Is that indeed the damage? So for these, we need both types of studies for sure. That's one. And two is the concern that we have. We're thinking about individual property damage is insurance companies, because we do not want this to be used against people who need to be protected the most. We haven't figured out that part yet. Well, we haven't figured, that's an idea. We're working on developing the method to begin with. And the last thing is, again, about specific pathways. I agree with you. We do need to look into this more, and I have other grants submitted or working on other projects to try and look into pathways. So is it, for example, through power outages? Is it through floods? Is it? But again, for this, we do need better detailed data instead of just an administrative hospitalization record to be able to look into, or some, mold. I'm guessing if the hurricane had a lot of water and floods that didn't evaporate, that, but we need measurements for that. So in summary, the answer is that we cannot answer with this data any of these questions. They are extremely important. And that's why we need to work with the communities, the impacted communities, to understand what has happened in the past, to help us best prepare for a worse, unfortunately, future.
Do you think that developing a cumulative exposure index will allow you to compare across regions for a comprehensive study? That might be an answer.
We are getting ready to test that. So hopefully I'll be able to answer in a few years. I think it depends, because I think some of the pathways, stress being the most important one, are shared. So if the pathway is shared, then maybe the specific exposure is not as relevant, other than it's a huge destructive and disruptive exposure. But we haven't tested that yet. So we need to, one, develop these metrics, run health analysis, run them by metric, by region, and then see if they're comparable, and then we'll know more. But that's the hope.
Thank you so much. And thank you for the answers to your questions. I think it really ties together a lot of what you talked about with what some of the local concerns here. You mentioned that even within California alone, spatially, temporally, even actually across different years, it varies a lot. So going back to Artie's question about cumulative exposure, how do you do this? This is going to be a really interesting thought developing those research questions in addition to getting to social determinants of health, structural damage, other, and multiple things happening in the same year. So, and I suppose right now we don't have a lot of data on multiple, cascading events. For example, extreme heat and humidity after a hurricane, and there's no power. So do you have any thoughts about that? I mean, it sounds like you're working on a couple of different fronts on this, but it's a very complicated milieu of exposures. It's more than a mixture, as you said, and it's got the spatial, the temporal, the social determinants that go in with the financial. So thank you.
Yes. I will be employed for many more years to come. All of us will. Sorry, this was not the time for jokes. I think that's very important. And first of all, we don't have the methods to begin with. But even before the methods is how do we even begin to conceptualize this? And going back to the discussion we had earlier, Katrina did not look the same as Harvey or as, Irma or as Sandy, and these are just hurricanes. They're not even just cyclones or. So I think it will be very important. I have, based on my training, I have thoughts on moving forward, but I think it's extremely important to get local information and information on lived experiences. In these studies I didn't have time to include this. We looked at social vulnerability and how vulnerability modifies the estimated associations. This was a nationwide study. We had tertiles of social vulnerability. What does this say about the social vulnerability spatial distribution within just New Orleans? Nothing. New Orleans was just one stratum altogether in one stratum. So I think it's extremely, extremely important to have both types of studies, both to study, things nationwide comprehensively, but also very locally. Nationwide studies will get the discussion started. Local studies will bring local solutions. So I think we need both, because also how I identify vulnerability at a nationwide level is very different than experience vulnerability locally. So I think we need both types of study, and we need people who do both types of study to sit down and think of that. And then once that happens and we have the conceptual definitions, then we go to biostatisticians and to, potentially computer scientists, machine learning, artificial intelligence experts. And then we're like, okay, we want help with this. But right now, all the biostatisticians I talk to just deal with this as that they're just, air pollution exposures, they're just numbers. So they are amazing, they're extremely smart, but we need to give them the full conceptual framework to get the methods that we need. Exactly. Yes, which again, cannot easily be done nationwide, but can be done locally much better. Exactly. No. Great. Thank you, everyone.